All right, guys. So we're going to do the adult cardiac arrest algorithm. This is stuff that can be found online. You can Google 2020 ACLS algorithms. This will pop up. I'll also make it available for you in your OneDrive, and this will be the same PDF that I hand out for you during ACLS. All right, so starting at the top, first thing we're going to do is start CPR. Remember, this is a adult cardiac arrest algorithm. So we're going to place the patient on the monitor, begin ventilations and high flow O2, and start CPR. Notice what it says over here on the right, CPR quality. We want to push hard, push fast, minimum 2 inches deep, and try to get about 120 compressions per minute. We want that chest to completely recoil so that we can allow those ventricles to fill with blood. We're going to minimize the interruptions as much as possible. We're going to avoid excessive ventilations because then we start filling up that gut with air. We want to change compressors every 2 minutes or if sooner if we start getting tired. If there is no advanced airway in place, remember that it is a 30-to-2 compression to ventilation ratio. However, once the patient is intubated, we can consider then, or will not consider, we'll just start ventilating the patient at 1 breath every 6 seconds. Also, once we get the patient intubated, it's a great time to put on qualitative waveform capnography. This allows us to justify our CPR. Is it effective or ineffective? We try to keep those ranges about anywhere from 15 to 20 on our CPR while performing CPR, our CO2 output. All right, so what we're going to do once we get that monitor attached, we're doing good CPR. As soon as we get it detached, ready to analyze the rhythm, we're going to stop CPR. We're going to analyze our rhythm. Are we in a shockable rhythm? So we can go yes or no. For this purposes right now, we're going to go to the left of the screen and we're going to go yes, they are in a shockable rhythm. So the shockable rhythms that we have is VFib and pulseless VTach. Once we verify that that patient is in VFib or pulseless VTach, we're going to immediately shock that patient. Now, if you're using our LifePak 15s like we use here in the classroom or your standard trucks in this area, that is immediately charge your monitor to 200 joules, deliver the shock. Now, once we deliver the shock, notice what we go to. Immediate CPR. Don't look at that monitor. Don't see what rhythm we converted to. Immediately go to CPR. While we're doing that 2 minutes of CPR, it gives us time to get IV-IO access. Now remember, we don't have to push IO access down the list like we used to. If we look at that patient, we don't see good vascular access, go straight in and give an IO. We can go humoral, we can go femoral. Once we get that IV access, if we get it while we're in that 2 minutes of CPR, go ahead and give us an epi. If you look over here on the right side, under the drug therapy, you see the epi dose. 1 milligram every 3 to 5 minutes IV-IO push. All right, so back over here, after 2 minutes of CPR, we're going to check, are we in a shockable rhythm? For the time purposes, we are going to stay in a shockable rhythm. So as soon as we detect we're in a shockable rhythm, again, VTach or VFib, we're going to immediately charge that monitor back up. This is our second shock. So we're going to give that patient now 300 joules. We're going to deliver the shock and immediately start back CPR. Notice it doesn't say check rhythm. Immediately start back CPR. If you hadn't got an epi in yet, now you can give your first epi. If not, remember that epi's every 3 to 5 minutes. Here's where we can consider an advanced airway and capnography. Keywords there, guys. Consider. If you have not gotten that IV, but you're getting good rise and fall of the chest wall with that BVM and the oral airway or nasal airway, we can push this airway on down the list a little bit. We want to get them drugs in there. All right, after 2 minutes of CPR, going to check our rhythm again. Are we still in a shockable rhythm? Yes, we're still in pulseless VTach or VFib. This is going to be shock number 3. Charge our monitor up to 360 and deliver the shock. Once we deliver the shock, immediately start back CPR. Now, this has been 3 shocks. So now we can consider an antidysrhythmic. Antidysrhythmic of choice is going to be amiodarone. So if you slide back over here to the drug therapy box, you'll see amiodarone IV dose. Our first dose for pulseless VTach or VFib is 300 milligrams IV push. So we're going to push it, go back to doing CPR. Now, if we're in that time frame where we are getting close to the end of that 3 to 5 minutes for the epi, let's go ahead and give another epi also. All right, 2 minutes of CPR. Notice how we go back up here to the top between steps 4 and 5 to detect the rhythm again. Are we still in a shockable rhythm? Yes, we are. So we're going to now charge our monitor to our max dose, which we hit on our previous shot, 360 joules, immediately defibrillate, and then go back to chest compressions. Given our epi, 1 milligram every 3 to 5 minutes, and we're going to continue that process. Now, our second dose of amiodarone, if you'll look over here, is 150 milligrams. So 150 milligrams IV push. Our first dose was 300 milligrams IV push. After about 1 cycle of CPR or 2 cycles of CPR, then you can give that second dose of 150 milligrams. Now, if you chose to go lidocaine instead of amiodarone, that first dose of lidocaine would have been 1 to 1.5 milligrams per kilogram. Then our second dose would have been 0.5 to 0.75 milligrams per kilogram. Now, you can continue giving that lidocaine dose until you hit a max total dose of 3 milligrams per kilogram. Now, that's not meaning you're building your way up to 3 milligrams per kilogram. What that's saying is, like, the first dose, if you give 1 milligram per kilogram, and the second time you give it, you give 0.5 milligrams per kilogram, you've given a total of 1.5 milligrams per kilogram. So you keep doing those increments until you reach a total of 3 milligrams per kilogram. Now, either we're going to get return of spontaneous circulation, or we're not. So we just keep looking and working our way around. If we do get return of spontaneous circulation, we want to then remember we have administered an IV push of an antidysrhythmic. So therefore, we have to hang an infusion of an antidysrhythmic. If we gave amiodarone, then we're going to give 1 milligram per minute of amiodarone. If we gave lidocaine, we're going to hang the 1 milligram above the total milligram given so far. So meaning maybe we gave 1 milligram per kilogram the first dose and then 0.5 the second dose. That means that patients had a total of 1.5 milligram per kilogram. To hang the infusion, we would hang the infusion at 2 milligrams a minute. Now, if we have not gotten return of spontaneous circulation, we would go down to the very bottom and we would start considering our H's and T's. Now, in the whole process of working this code, we're going to try to rule out these H's and T's anyway, so that we can try to let that help us get our return of spontaneous circulation. So we're going to look at hypovolemia. Well, we should be correcting that anyway because we're probably running fluids in this patient as we're coding them. Hypoxia. Well, if we've got them intubated, we got good capnography waveform, we got rise and fall of the chest, we're correcting that if they're on high flow O2. Hydrogen ion acidosis. Well, that's kind of hard to do in the field because we ain't got a way to run labs. But however, we can know that prolonged downtime and prolonged low O2 sats and stuff like that's going to automatically cause us to have an elevated hydrogen ion access. So we're just going to go ahead and treat for that by giving them fluids and high flow O2. Hyperkalemia. That one's kind of difficult. Usually don't see it unless once we get the code back and we start looking at some electrolyte disturbances either in the hospital setting, or we might can see those trying to show their faces in our peak T waves or depressed T waves. However, we can also look at it as is this a dialysis patient, stuff like that. So there's where your sodium bicarb and your calcium comes into play with dialysis patients. Then you got hypothermia. Well, your patient, are they cold to the touch, warm to the touch? Remember, go to the core. Tension pneumothorax, or are we dealing with a trauma patient versus non-trauma patient? Or when we were just ventilating that patient after intubation, did we have decreased breath sounds on right or left side? If so, and the clinical indicators are there for possible pneumothorax, then let's fix it. Let's needle decompress that patient. Then you got cardiac tamponades. You got your toxins. Is there anything that suspects us to believe that the patient might be under some form of drugs or poisoning, accidental or intentional? Thrombosis, pulmonary. So what was the patient's complaints prior to going unresponsive? Was it shortness of breath? Anything that leads us down the PE route, or anything that leads us down the ACS route, acute coronary syndrome route, as far as thrombosis for coronary. All right, so if we go back up here at the top, where we start CPR and then we go to shockable rhythm. Let's look at it now and say that the patient is not in a shockable rhythm. So they are PEA or they are systole. First thing we need to do is start CPR again, and get an IV as soon as possible and administer epinephrine. Again, epinephrine is the same dose, 1 milligram every 3 to 5 minutes. We're going to try to get an airway in as soon as possible. And every 2 minutes, when we stop and check rhythms, we're going to decide, are they in a shockable rhythm or not? If they're not, we're just going to continue that cycle over and over. CPR CPR for 2 minutes, 1 epi every 3 to 5 minutes. And we're going to continue that over and over, using the same concept of trying to correct any of those reversible causes we have, which are those H's and T's at the bottom. So guys, that's pretty much cardiac arrest algorithm. It's pretty simple. Obviously, if we go to the left, it's a little bit more work and math that's involved in it. But if we stay on the right side, it's pretty self-explanatory and just a cycle that goes over and over. The hardest part about going to the left on the shockable rhythm side is when you make that initial shock or those subsequent shocks, you want to look at that monitor and see if that patient has a return of pulse or change in rhythm. It's the worst thing we can do, and on a national registry standpoint, that's almost a failing criteria. When you deliver that shock, you want to immediately go start back chest compressions and continue providing chest compressions and mechanical ventilations and drug therapy until that 2 minutes comes back up. That's when you'll check and see if you've got a rhythm change. All right, guys, if you got any questions, text me, email me, and that's cardiac arrest algorithm.